Thank you. It's a real honor to be here, and I've enjoyed all the presentations thus far. These are my disclosures. We know from a mountain of evidence that 2 ITAs are better than 1. This is the seminal paper from 1999 from Bruce Lytle and others at the Cleveland Clinic demonstrating that in terms of reintervention and long-term survival, BITA outperforms CETA. Dr. Taggart published now over a decade ago this meta-analysis of BITA versus CETA, again with a significant benefit for the BITA group. Takagi, much more recently in the JTCVS, looked at 20 observational studies pooling over 70,000 patients and demonstrating that a BITA was associated with significant reduction in long-term mortality relative to CETA. Interestingly, that benefit increased in series containing a lot of male patients. This is the forest plot from that meta-analysis, and whether the ITA is pedicled or skeletonized, the net benefit was strongly in favor of BITA for long-term survival. From the Cleveland Clinic, very recently, about 12,000 patients with diabetes having coronary bypass, and studying the BITA versus CETA, we saw that BITA was associated with an increased risk of deep sternal wound infection, especially in obese female patients with prior MI, peripheral vascular disease. Off-pump bypass and on-pump bypass had similar outcomes, and complete versus incomplete revascularization had similar in-hospital outcomes, but complete revascularization had a better longer-term survival. BITA grafting with complete revascularization maximized the long-term outcome, and this particular paper cautioned against BITA grafting in obese diabetic females. This is the wonderful Cleveland Clinic smooth grafts. I don't know how they get these grafts. I can't get my computer to draw a line that perfectly. But in any case, these are the cohorts: BITA grafting with complete revascularization, BITA grafting with incomplete revascularization, CETA grafting with complete revascularization, CETA grafting with incomplete revascularization, vein only with complete revascularization, and vein only with incomplete revascularization. You can see a gradation in survival outcomes over 20 years. And so data like those informed these 2011 CABG guidelines that I had the privilege of presenting to the AHA on behalf of our group of writers, indicating that we should use a second ITA graft to bypass the left circumflex or right coronary artery when critically stenosed to improve likelihood of survival and decrease reintervention. And the complete arterial revascularization was reasonable in younger patients. Arterial grafting to the right coronary artery is reasonable with a tight stenosis, I think in the right territory. Concern about competitive flow is more significant, and use of a radial artery may be reasonable when grafting significant stenosis on the left or critical stenosis on the right. There is a cautionary note, though, that an arterial graft should not be used to bypass the right coronary artery with less than critical stenosis. These are the European guidelines for 2014. Interestingly, the European guidelines are more detailed, especially in the way that the guidelines writers are willing to advocate how surgeons should perform their operation, not just when. Recommending, for instance, endoscopic vein harvesting, routine skeletonization of the IMA, complete revascularization, arterial grafting with an IMA, bilateral ITA grafting, utilizing the radial artery for vessels with high degree stenosis, and recommending total arterial revascularization, minimizing aortic manipulation, off-pump bypass for high-risk patients in skilled centers, minimizing the risk of aortic manipulation, intraoperative graft assessment. So much more detailed assessment or recommendations within the European guidelines. Since those were published, there are some other papers in the literature, this one from my center, my relatively new center here at Mount Sinai Heart at Beth Israel, in New York City, looking at radial artery grafting. This is a survival study, case-match trial with several thousand patients, looking at the survival of patients who have a LITA with a radial artery to a second target or a LITA with all veins. And you can see that over 15 years of follow-up, survival is substantially better in the unadjusted and in the risk-adjusted groups or comparisons, so that multiple arterial bypass grafting saved lives And if you did the mathematics from our set of several thousand patients and applied it to several 100,000 patients in the United States of America, you would save literally tens of thousands of lives. And so we made the argument this should be routine. Fred Moore from Germany had a similar commentary in this review article, again published very recently. Buxton and Tatoulis from Australia, again very recently, since those guidelines were published, looking at total arterial revascularization out to 10 years in case-matched comparison with a very large series of patients from Australia, demonstrating superior survival with total arterial revascularization compared to non-total arterial revascularization. So we recently looked with colleagues made an attempt to try to develop an algorithm to choose conduits for coronary artery bypass grafting. And this is, I don't know how well this projects at that screen, perhaps it's legible. We're looking at patients with no major risk factors for postoperative medial stenosis and those who do have major risk factors. In the less risky patients with target stenosis greater than 70% on the lateral wall, we recommend arterial grafting. On the inferior wall, if it's tight, if it's not tight, rather, a vein graft. If it is tight, an arterial graft. For those with less than 70% stenosis on the lateral wall, again a arterial conduit, and on the inferior wall, a saphenous vein conduit. For those patients with severe, with major risk for medial stenosis, we prefer away from double mammary grafting and use radial arteries or GEAs. David Taggart and I, with a young colleague, wrote this invited editorial in the Annals, published just a month or two ago, to accompany the STS Workforce on Evidence-Based Surgery's new clinical practice guidelines on arterial conduits. They performed a systematic review of literature and recommended some nuanced changes to the previous guidelines that I showed you moments ago. Recommending bypassing the LAD with an ITA, not specifically the left ITA, but recognizing that the right ITA can be used as an equivalent graft. Recommending the use of a second arterial conduit and not specifying whether it be a radial or a RETA because both are shown superior to a vein graft. Recommending BITA whenever the risk of deep sternal wound infection is acceptable. Recommending a skeletonized BITA harvest with other adjunctive changes in behavior and management to reduce risk of sternal wound infection. These new guidelines do not specify a minimum native stenosis for the use of a radial graft, but recommend it for severe stenosis. And we eliminated the age threshold for arterial revascularization because it seems that there is no upper limit beyond which arterial grafting shows no benefit, and certainly none where it's a disadvantage. This is a comparison we created of the 2011 guidelines, the European guidelines, and these recently updated practice guidelines for arterial grafting. And I'll draw your attention to that. There are some technical details of how we perform arterial grafting that are important. I think it's important to recognize that the risk of spasm of arterial conduits is directly related to the amount of trauma they experience during harvest and grafting. Atraumatic harvest technique may be more important than pharmacologic prophylaxis in preventing spasm. And we prefer to skeletonize the ITA with an ultrasonic scalpel. It is important, however, to contemplate and think carefully about native competitive flow patterns when performing complex multiple arterial grafting, especially when we're using composite and sequential grafting in the setting of unbalanced competitive flow in the multiple arteries being bypassed. Precise anastomotic technique is a given, and we do prefer to document patency with intraoperative Doppler assessment. It's our opinion that all arterial clampless off-pump bypass may combine the benefits of minimizing perioperative stroke and maximizing long-term benefit. We do think that the present advocacy in our guidelines and STS quality metrics for a single artery graft should be expanded to multiple arterial grafts, and that should be rewarded by CMS. Dr. Mack kindly referred to this recent editorial in the JTCVS, and I will skip over that. Should the internal thoracic artery be skeletonized? David Taggart provided me with this slide. Does it cause arterial injury? No. Does skeletonization affect graft patency? Apparently not. Does it affect flow? It does seem to make the flow better. This is old information. Also an old study. Skeletonization reduces sternal wound infection, especially deep sternal wound infection, and restores the rate of sternal wound infection to baseline in diabetic patients. How does it do that? It improves tissue oxygenation and retrosternal blood flow. There's less damage to the inside of the chest wall with a skeletonized harvest than with a pedicled harvest. There are multiple ways to do skeletonized ITA harvest. You can clip, and cut. You can use the Bovie cautery on low power or the harmonic scalpel. Teresa Kaiser from Calgary, Canada, has an immense experience in harvesting bilateral ITAs with the harmonic scalpel and assures us that she can do it reliably in a mean of 15 minutes per side. This is a less skilled surgeon myself, taking about 25 minutes per side to harvest the internal mammary artery using the harmonic scalpel. The harmonic scalpel liquefies the fat and literally vaporizes it. You notice that this harmonic device actually can come in contact with the ITA without damaging it, whereas a cautery cannot. We use the forward edge of the harmonic scalpel to cauterize the side branches. It takes just a moment longer. And then the hook portion to divide the side branch. Again, we couldn't do this with cautery because it would produce spasm and injury to the vessel. We deploy the skeletonized BITAs in multiple different ways. These are the most common strategies in my practice. An in situ LITA to the LAD, sometimes sequential to the diagonal. A RITA through the transverse sinus in situ to approach the marginal system. Sometimes we extend the RITA with a piece of radial artery, or it can reach directly to the right coronary or the PDA. We sometimes bring the RITA across the midline anteriorly to the LAD, in which case the LITA goes to the lateral wall. We sometimes build composite grafts, taking the RITA as a T off the LITA. Whenever the RITA would be under tension reaching the LAD, we use it as a composite off the side of the LITA, creating a T graft like this and testing the flow in both limbs. Does it matter which way you use it? Apparently not. David Glenor, in this interesting paper in Circulation, demonstrated that whether in situ or Y configurations, the BITA performs similarly. There are other ways to use it. It can be as an in situ LITA to LAD twice for serial lesions in the LAD. We can take a radial artery off the RITA to reach the PDA. A radial artery itself may be teed off the side of the LITA to go to the lateral wall. And in fact, you can take the radial artery as a side-to-side graft, we call that a K graft, off the LITA with a short limb going to the diagonal and a long limb going to the lateral wall. Again, a fundamental advantage of skeletonized BITA is the opportunity to avoid aortic manipulation and reduce sternal wound infection. And this is one of the possible patterns in which it can be used. Here is another that you saw earlier with no aortic touch for an aorta with severe disease, multiple arterial inflows and multiple arterial outflows. This is a K graft in a setting where we have critical lesions in the LAD diagonal and obtuse marginals. We can take a lima and a radial artery side to side with a short limb to the diagonal and the long limb around the back to the obtuse marginal. This kind of complex sequential arterial grafting demands that you consider the competitive flow. In this particular angiogram, you can see there's very little competitive flow and that it is relatively balanced across these outflows. So why is BITA grafting so infrequently performed? Only about 5% of isolated primary coronary bypasses in the STS database have double mammary grafting. In Europe, it's about 10%. In Japan, it's about 50 to 60%. Why do U.S. surgeons perform so few BITA grafts? Frankly, I think it's not just that we're lazy and unskilled. That may apply selectively, but really I think it has to do with our practice environment. Fear of deep sternal wound infection is in an increasingly obese diabetic population of patients. The FREEDOM trial, as Dr. Mack eloquently stated earlier, has yielded an uptick in volume of coronary bypass patients in the United States of America, but they're not great patients. They tend to be obese diabetic females. There are political disincentives to have a deep sternal wound infection. The surgeon pays a large and immediate political price for a deep sternal wound infection and gets no credit for the extra years of life that the BITA graft may add to a patient's experience a decade or two later. The surgeon may have retired by the time that occurs. Surgeons are increasingly employed by hospitals and are under intensive pressure to optimize their short-term metrics of quality. And there are actually financial disincentives. The Center for Medicare Services in the United States of America has labeled the deep sternal wound infection a never event. It should never happen, implying that if it ever happens, it's someone's fault, and the government's not going to pay for it. So the readmission for deep sternal wound infection in the United States of America is gratis. The hospital and surgeon eat the cost of care. There is no reimbursement. Now, if that surgeon is employed by the hospital, they literally count the number of deep sternal wound infections that come back. So these are a powerful disincentive to perform double mammary grafting. So we looked very carefully to try to figure out, all right, in which patients can we get away with it because we know it's a good thing to do when we can. We first looked at preoperative hemoglobin A1C and how it interacts with sternal wound infection in patients undergoing single and double mammary grafting. I did this when we were still at Emory University, looking at a study period of 5 years, 6,000 patients, 81% had preoperative hemoglobin A1C levels in our computer, about 10% had beta grafting. The skeletonization was performed by surgeon discretion, about 70% were off pump, and all of the patients had similar glucose management protocols. In a multivariable logistic regression, BITA versus CETA, BITA was associated with an increased risk of sternal wound infection of about 2.8-fold. A1C, whether above or below 7%, had an almost identical relative risk ratio for deep sternal wound infection. And continuous hemoglobin A1C, this is the adjusted odds ratio for every unit increase in hemoglobin A1C, was about 1.3. So in conclusion of that study, beta grafting and hemoglobin C are both independent predictors of deep sternal wound infection at about 2.8-fold. Hemoglobin A1C can be utilized to estimate the risk of deep sternal wound infection after beta or CETA grafting. And in patients with well-controlled diabetes, the risk of deep sternal wound infection is comparable to patients without diabetes. A1C provides an objective and quantifiable measure of risk. So then we just thought, well, okay, we've looked carefully at what the risk is of doing a doing a bilateral ITA graft in terms of deep sternal wound infection. What's the payoff in diabetics? Because it occurred to us that all those papers going back 20 years at the Cleveland Clinic showing survival benefit with beta were done at a time when we had less than 10% of patients referred for coronary bypass who were diabetic. The vast majority of those patients from those old papers that we all trust and believe in, those were non-diabetic patients. Almost none of them had diabetes. Now, Freedom is sending us mountains of patients with diabetes. Do the same rules apply? No one had actually ever looked at that. So we did. And we presented this at STS a few years ago. This was a sample of 11,000 primary coronary bypass patients performed by the entire faculty at Emory University, excluding emergencies and single ITAs, single vessel disease. We had about 9,000 patients. We chose to look only at those patients operated by 3 surgeons who actually cared about bilateral ITA grafting. A rather sorry commentary that in that period of time, of the 17 faculty surgeons at this august academic institution in the United States of America, only 3 of them did a measurable amount of beta grafting. That's the truth. Those surgeons did between 10 and 40% of their cases with beta. You can guess who the 40% was. This is a selection of how we basically made up our minds about who would get a beta and who would get a CETA. Beta patients tended to be more male, non-smokers with better ventricles and more diseased vessels. CETA patients tended to be more obese, diabetic, smokers with peripheral vascular disease, renal failure, arrhythmia, and CHF, cerebrovascular disease as well. And in terms of deep sternal wound infection, the incidence of diabetes increased during the study. So from 2002, we had about 40% of patients with diabetes. In 2010, it was 50% of patients who were having coronary bypass surgery had diabetes. Overall, deep sternal wound infection was more common among diabetics than non-diabetics. And patients with deep sternal wound infection had a higher hemoglobin A1C than those who did not suffer wound infection. Deep sternal wound infection was similar within non-diabetic patients and within diabetic patients, whether you had beta or CETA, which doesn't tell you that beta has no risk. It just tells you that we very carefully parsed out those patients that would get beta or CETA within the diabetic and non-diabetic populations. Beta patients had similar deep sternal wound infections compared to CETA, with that careful parsing. Okay, so did it improve long-term survival in diabetics? Yes. Beta grafting confirmed a 35% reduction in hazard of death over 10 years of follow-up, and this benefit was equal for non-diabetic and diabetic patients, no difference. So yes, beta grafting makes diabetics live longer than CETA grafting, just as beta grafting makes non-diabetic patients live longer than CETA grafting. And if you graph out, this isn't quite as beautiful as the Cleveland Clinic. We must have different computers. Here's the beta non-diabetic patients surviving best, beta diabetic patients surviving second best, CETA non-diabetic patients doing less well than beta diabetic patients over longest term follow-up, and the split being at about 6 years, and CETA diabetic patients doing least well. All of that is retrospective, and David Taggart will soon reveal to the world the 10-year outcomes from this landmark trial that you all participated in here in Europe. 3,100 patients randomized to CETA or beta with excellent perioperative and 30-day and 1-year outcomes, but a sternal or risk of deep sternal wound infection requiring reconstruction of 0.6% in CETA and 1.9% in beta, a relative risk of 3.2, very, very similar to the 2.8 relative risk that we found at Emory. So that isn't different on either side of the pond. If you find coronary surgery interesting, perhaps you'll enjoy coming to this meeting that EACTS is putting on in India in November. Thank you.